Somatic symptom and related disorders sit right at the crossroads of body and mind, making them some of the trickiest and most misunderstood conditions in counseling. The DSM 5 TR doesn't just focus on whether symptoms have a medical explanation, but on how much distress and disruption they cause. It's not about whether the pain or fatigue is real, it absolutely is, but about how thoughts, emotions, and behaviors around these symptoms affect daily life. And this is where counselors step in, not to dismiss, but to help clients understand and manage their experience in a way that leads to less suffering and more balance. Somatic symptom and related disorders cover a whole range of presentations. Somatic symptom disorder, or SSD, is about the symptoms themselves: constant pain, fatigue, dizziness, where worry and focus on them take over. Illness anxiety disorder, on the other hand, is about the fear of the disease. So think WebMD spirals and endless doctor visits out of total avoidance out of fear. And then there's conversion disorder, where stress and trauma can translate into neurological symptoms like paralysis or seizures, even when there's no medical cause. And then let's not forget about factitious disorder, where symptoms are intentionally faked for psychological reasons, not for money or avoiding responsibilities. That would be called malingering, and that's not a disorder. So, a big debate about somatic symptom disorder is whether persistently high anxiety about symptoms belongs in the criteria. Some argue it unfairly labels rational concern. Like if you've got a serious health condition, of course you're going to be anxious about it. But the key is whether the anxiety takes over, leading to excessive doctor visits, avoiding life activities, or deep distress that goes beyond what's typical. Counselors are not here to tell clients it's all in your head, that's the worst, but help them cope with real distress, whether it's from symptoms, anxiety about the illness, or both. And the real challenge is that clients with somatic symptoms and related disorders often feel invalidated. Being told that everything's fine when you're struggling feels awful. And that's why counselors need to take symptoms seriously while shifting the focus from endless medical testing to symptom management. This is where the mind body work shines. CBT, mindfulness, breathwork, and somatic therapies can all help break the cycle of symptom anxiety and hyperfocus. At the end of the day, our job isn't to separate the physical from the mental, it's all connected. Our role is to help clients feel heard, teach them tools to manage their distress, and guide them toward a life that isn't controlled by symptoms. So, somatic symptoms and related disorders can be a tough category for both clients and counselors. Why? Because these disorders live in that messy, complicated space between physical and mental health. The DSM 5 TR defines SSRDs as conditions where physical symptoms, pain, fatigue, dizziness, or other bodily sensations can cause significant distress or interfere with daily life. But medical tests don't fully explain them. The key here isn't whether symptoms exist, they absolutely do, but how much they impact a person's life. For a long time, mental health and physical health were treated as separate worlds, and SSRDs were often misunderstood or worse, dismissed entirely. If there wasn't a clear medical explanation, people were told it was all in their head. So just accuse the frustration and endless doctor visits. But we know now that body and mind are deeply connected. Stress, trauma, and emotions can show up physically, and chronic physical symptoms can in turn create emotional distress. SSRDs sit right at this intersection, making them a classic example of why counselors need to take a holistic approach. If you've ever heard the term somatoform disorders, you might be wondering what changed. The DSM 4, this category was largely defined by medically unexplained symptoms. If the doctors couldn't find a reason for the symptom, it was classified as a mental health issue. The problem? This approach didn't always reflect reality. Many people with SSRDs do have underlying medical conditions, but their emotional response to the symptoms is what's causing the biggest disruption. The DSM 5 TR took a more client centered approach, shifting the focus from whether a symptom feels real to how a person experiences and responds to it. And this change was meant to reduce stigma, because nothing is more invalidating than told that your suffering isn't real, to recognize that medical and psychological factors are intertwined. We are whole humans, not a bunch of separate systems. And to improve treatment approaches, helping counselors focus on managing distress instead of proving or disproving symptoms. And to really understand SSRDs, we need to think bigger than just the body or mind. And that's where a biopsychosocial model comes in. This model recognizes that biological, psychological, and social factors all play a role in how people experience symptoms. Biological factors could include genetics, nervous system dysregulation, pain sensitivity, or past medical conditions. Psychological factors like anxiety, trauma, coping skills, and even personality traits can shape how someone perceives and reacts to their symptoms. And then there's social factors like family beliefs about health, cultural attitudes towards illness, and access to medical care, all influence symptom management. For counselors, this model is key to effective treatment. Instead of dismissing symptoms or assuming that they're purely psychological, We can explore how stress, trauma, thought patterns, and social support systems might be playing a role. And this opens the door to meaningful interventions, from CBT and mindfulness to somatic therapies and lifestyle changes that can help clients reclaim their lives. SSRDs are tricky, but they also show us why mental health care needs to be flexible, validating, and holistic. As we dive deeper into the specifics of each disorder in this chapter, the big takeaway is this: our job as counselors isn't to separate physical and mental health, it's to help clients navigate both in a way that makes them feel heard, seen, supported, and empowered. Each disorder within somatic symptoms and related disorders has unique features, but they all share a common thread. And that's the interaction between the body and mind that leads to significant distress and impairment. So let's break them down one by one. So, starting with somatic symptom disorder, or SSD, it's all about the symptoms. A person with SSD experiences one or more persistent physical symptoms like chronic pain, fatigue, or dizziness that cause significant distress or interfere with daily life. Unlike illness anxiety disorder, which we'll talk about next, where the focus is on the fear of the disease, SSD is about the intensity and impact of the symptoms themselves. Key features include distressing physical symptoms that can't be fully explained by a medical condition, excessive thoughts, feelings, or behaviors related to health concerns like constant worry, checking behaviors, seeking repeated medical reassurance, and it also has to be chronic. Symptoms persist for at least 6 months, even if they fluctuate in intensity. And the specifiers for this disorder are predominant pain, so that would be if the pain is the main or only symptom; persistent, symptoms are severe, long lasting, and disabling; and then there's severity levels: mild, moderate, severe. So mild is only one excessive health related thought or behavior, moderate would be two or more, and then severe is multiple symptoms plus extreme distress or impairment. So an example here would be a client experiences chronic stomach pain, has seen multiple doctors, and undergoes repeated medical tests, but remains convinced something is seriously wrong despite all results being normal. They spend hours researching symptoms online, frequently calling their doctor, and having trouble focusing on work or relationships because of their health concern. So, moving on to illness anxiety disorder, formerly known as chondriasis, not about symptoms, it's about the fear of disease. People with illness anxiety disorder believe that they have or will get serious illness, even though medical evaluations show no evidence of one. So, some key features here are preoccupation with having or acquiring serious illness despite minimal or no symptoms, high levels of health related anxiety leading to excessive checking, like frequent doctor visits, or avoidance, like refusing to see a doctor. And this is going to persist for at least 6 months, even if specific illness fears shift. And there's two subtypes here that we want to be mindful of. There's the care seeking type. So that's the one with the frequent visits to doctors. They're going to request tests. They're going to seek reassurance from professionals. And then there's also the care avoidant type, which is going to avoid doctors, hospitals, and medical tests out of fear of receiving bad news. So a person with illness anxiety disorder might have a mild headache, but become convinced it's a brain tumor, repeatedly check their pupils for changes, and visit multiple neurologists only to leave each appointment still convinced something was missed. For functional neurological symptom disorder, or FNSD, also known as conversion disorder, it's all about neurological symptoms that don't match with medical findings. The body's saying, I can't, but the brain isn't sending signals that would explain why. These symptoms can range from paralysis to seizures, blindness, speech difficulties, all without medical evidence to support them. Key features here are sudden onset of neurological symptoms, often triggered by stress or trauma, symptoms that don't align with other known medical conditions like normal test results despite severe weakness, and not intentionally produced. And we're going to get to that in the next one when we talk about factitious disorder or malingering. So an example here would be after a major car accident, a person loses their ability to walk, but doctors find no nerve or muscle damage. The symptom is real to them, but there's no medical explanation that fits. So a quick little mnemonic to help you remember this: think of it as can't version disorder. The person can't move or feel parts of their body, even though nothing is medically wrong. And the next one that I just talked about a little bit, that factitious disorder imposed on self or another, also known as Munchausen syndrome or Munchausen by proxy. And this is a disorder about deception, but for psychological reasons. A person fakes, exaggerates, or induces symptoms to assume the sick role, often craving attention, sympathy, or a sense of control. Unlike malingering, which is not a diagnosis, there's no external reward like money or avoiding work. It's all about being seen as ill. So, key features for factitious disorder are intentional falsification or induction of symptoms, no obvious external reward like financial gain or legal avoidance. And then there's factitious disorder imposed on another, or Munchausen by proxy. And this is when the person would induce illness in somebody else, like a parent harming a child to gain attention from doctors. So, an example for factitious disorder imposed on self would be a person injects insulin to fake hypoglycemia and enjoys the attention that they receive at the emergency room. An example of factitious disorder imposed on another would be a mother poisons her child to keep them sick, relishing the sympathy from doctors and caregivers. So I want to just touch base on malingering because I know I've said it a couple times. Malingering is not a mental disorder. It's a behavior pattern where symptoms are faked for external gain. So disability payments, avoiding military duty, getting out of legal trouble. We talked about that a little bit in that last lecture, looking at you, Walter White. But remember, factitious disorder is for psychological gain, tension, care, sympathy. Malingering, not a disorder, is for external gain, money, drugs, legal benefits. And then that brings us to psychological factors affecting other medical conditions. So this is a disorder about how psychological or behavioral factors make a real medical condition worse. It's not about faking or exaggerating. It's about the mind influencing an actual illness. Key features here are a real diagnosed medical condition like heart disease, diabetes. Psychological or behavioral factors worsen symptoms, delay recovery, or increase risk. So, an example here might be anxiety worsening asthma by triggering panic induced attacks, depression leading to poor diabetes management, like not taking insulin, not following a diet, not exercising, and high stress raising blood pressure in someone with hypertension. So, an example here would be a client with ulcers caused by H. pylori who continues to eat spicy foods, drink excessively, and ignore medical advice despite knowing it worsens their conditions. The psychological component, avoidance, denial, coping mechanisms contribute to a real physical harm. So, what's the key takeaway for all of these? Counselors are not here to prove if symptoms are real or not. We're here to help clients manage their distress, improve functioning, and reclaim their lives. And when trying to understand why some people develop persistent physical symptoms tied to psychological distress, we have to look at the bigger picture. Somatic symptoms and related disorders don't emerge in a vacuum. They're influenced by biological, psychological, and sociocultural factors. Some people may be biologically wired to be more sensitive to pain or bodily sensations. Others may have learned illness behaviors in childhood, especially if they grew up in environments where expressing distress through physical symptoms was common or reinforced. Think about when you were sick and maybe stayed home from school. Maybe your mom brought you some chocolate ice cream in the middle of the day. Maybe you were allowed to watch TV all day. There's ways that we are rewarded or reinforced by being sick. And of course, social and cultural factors shape how symptoms are perceived, expressed, and treated. Rather than thinking of somatic symptoms and related disorders as a single cause-effect kind of disorder, it's helpful to see them as a web of interconnected influences that make somebody more vulnerable to developing persistent and distressing physical symptoms. So let's break it down a little bit. For some individuals, biological factors set the stage for increased symptom sensitivity and distress. These aren't strictly genetic disorders, but research suggests that certain physiological traits can make somebody more prone to experiencing and focusing on physical sensations. Some people are simply wired to feel more pain than others. This isn't a personality flaw, it's a biological difference in pain perception. Studies suggest that heightened pain sensitivity and somatic awareness can run in families. A person whose parents or siblings experience chronic pain conditions may be at higher risk for developing similar concerns. And as far as neurological dysfunction in pain perception and interoception, interoception is the ability to sense and interpret internal bodily signals like your heartbeat, digestion, muscle tension. Some individuals have heightened interoceptive awareness, meaning that they feel every tiny bodily change and sensation more intensely. The brain's pain processing regions, the anterior cingulate cortex and insula, may be overactive, making bodily sensations feel more alarming or painful than they actually are or would be to other people. In conditions like fibromyalgia and irritable bowel syndrome, we see evidence that pain signals are amplified in the brain even when there's no actual physical damage. And this pattern may be similar in somatic symptom and related disorders. So an example here, just to kind of put it into context. Two people stub their toes. One barely notices while the other feels intense throbbing and pain that lingers. Their nervous systems process the same input differently, and this is how biologically sensitive pain can shape the way that somatic symptom and related disorders develop. Moving on to the psychological factors, how trauma, mental health, and learned behaviors shape these disorders. A person's life experiences, emotional regulation patterns, and coping mechanisms play a huge role in the development of these disorders. Many individuals with SSRDs have a history of early trauma, chronic stress, or difficulty processing emotions, leading to physical symptom expression as a form of distress communication. Adverse childhood experiences, or ACEs, such as neglect, abuse, or an unpredictable home environment, are strongly linked to higher rates of physical health issues and chronic pain later in life. For some, emotional distress wasn't safe to express in words, so the body became the voice, converting emotional pain into stomach aches, headaches, dizziness, and fatigue. That HPA axis, which regulates stress hormones like cortisol, may become dysregulated, leading to heightened body sensitivity and increased symptom awareness. And if sickness was a primary way to receive care, attention, or escape stress in childhood, the person may unconsciously carry that pattern into adulthood. That doesn't mean that symptoms are fake. It means that the body has learned that being ill is a way to cope with stress. And anxiety increases bodily awareness, making normal sensations feel more intense and alarming. Depression reduces pain tolerance and can contribute to fatigue and low energy. Trauma survivors often experience somatic symptoms like chronic pain, tension, and digestive issues due to long-term nervous system activation. And even thinking about OCD or obsessive compulsive traits, repetitive checking behaviors, scanning for lumps, taking vital signs are common in illness anxiety disorder, mirroring patterns seen in OCD. So, an example would be a child who grew up in a home where expressing emotions was discouraged, but being sick led to comfort and attention, may lead to unconsciously expressing distress through physical symptoms later in life. And then talking about how society shapes symptom expression. Culture, medicinal experiences, and social attitudes shape how people interpret, express, and respond to symptoms. These diagnoses are not one size fits all. They show up differently across cultures and healthcare systems. There's this big fancy word, medical iatrogenesis, which just means the unintentional reinforcement of the sick role. In some cases, excessive medical testing and over-investigation can reinforce the belief that something must be seriously wrong. If a person repeatedly seeks medical care and receives no definitive answers, this can lead to increased anxiety, frustration, and doctor shopping. Sometimes well-meaning medical professionals can accidentally reinforce somatic symptom behaviors by continuing to pursue unnecessary tests instead of addressing the psychological aspect. And different cultures have different ways of expressing psychological distress, and in some communities, physical symptoms are the preferred way to communicate emotional suffering. For example, there's susto in Latin America, and this is a belief that fright or soul loss causes bodily symptoms like insomnia, digestive issues, and nervousness. We would call that generalized anxiety disorder usually, but this is something completely different culturally. Soul loss is a really big existential deal. Key takeaways here. Why does this matter for counselors? SSRDs aren't just about the body. They are about the body and the mind working together in ways that can be confusing, distressing, and disruptive. Some people are biologically more sensitive to pain and bodily sensations, making them more prone to experiencing physical symptoms. Early life experiences shape how people learn to process distress, sometimes leading to unconscious symptom expression as a coping strategy. Cultural and social influences impact how symptoms are experienced, explained, and treated, which means counselors must approach each case with cultural humility and curiosity. Somatic symptom and related disorders are tricky to diagnose because many other mental health and medical conditions also involve physical symptoms. A key challenge in counseling is determining whether physical symptoms stem from an underlying medical condition, a primary mental health disorder, or a combination of both. SSRDs exist at the intersection of mental and physical health, which mean that we have to carefully differentiate them from other disorders that can look similar. A differential diagnosis ensures that clients receive the right to support and interventions. Misdiagnosis can lead to unnecessary medical procedures, frustration, and untreated psychological distress. So let's break down how SSRDs overlap with other mental disorders and medical conditions and how we can tell them apart. Since SSRDs involve excessive focus on bodily symptoms, they can resemble other mental health conditions that also feature physical complaints, excessive worry, or distorted beliefs. So here's how they compare. Starting with depressive disorders versus somatic symptom disorder. Both depression and somatic symptom disorder can involve fatigue, pain, and gastrointestinal discomfort. But the differences are that in depression, physical symptoms are usually secondary to low mood and tend to improve as the depression lifts. In somatic symptom disorder, the focus is on the symptoms themselves. They remain distressing and impairing even in the absence of a mood disorder. So a client with major depressive disorder might report chronic fatigue and body aches, but their primary complaint is persistent sadness and loss of motivation. Meanwhile, a client with somatic symptom disorder is preoccupied with the symptoms themselves and may spend excessive time researching or seeking medical reassurance. Moving on to panic disorder versus illness anxiety disorder. Both can cause racing heart, dizziness, shortness of breath, and a sense of impending doom. The differences are that panic disorder is about sudden, intense episodes of fear or panic attacks that come out of nowhere. Symptoms peak within minutes and fade afterwards. Illness anxiety disorder is a persistent, ongoing worry about health. What if this dizziness means that I have a brain tumor? Even without significant physical symptoms. Moving on to obsessive compulsive disorder versus illness anxiety disorder, they're similar because both involve repetitive health-related behaviors such as checking vital signals, seeking reassurance, or researching symptoms. In OCD, compulsions are performed to neutralize distressing, intrusive thoughts. If I don't check my pulse 50 times, I'll die. Versus in illness anxiety disorder, checking behaviors stem from genuine, though excessive concern about health, not from rigid compulsive rituals. And then looking at delusional disorder somatic type versus somatic symptom disorder or illness anxiety disorder, they're similar because all of these involve firm beliefs about having a serious illness. Delusional disorder somatic type involves a fixed false belief or delusion that doesn't change even with evidence. Like doctors are hiding my real diagnosis from me. Versus somatic symptom disorder or illness anxiety disorder involve health concerns that cause distress but are more open to doubt and reassurance. So a client with somatic symptom disorder may worry that stomach pain is a sign of cancer, but will at least consider a doctor's reassurance. Meanwhile, a client with delusional disorder somatic type may believe they are infested with parasites despite multiple negative lab results and accuse of covering up the truth. And one of the biggest challenges in diagnosing somatic symptoms in related disorders is distinguishing them from real underlying medical conditions. Many chronic illnesses have symptoms that overlap with all of these. Think of fibromyalgia, irritable bowel syndrome, chronic fatigue syndrome versus somatic symptom disorder. So again, how they're similar is that chronic pain, fatigue, and gastrointestinal discomfort are common in both SSD and medical conditions. And these conditions often don't show clear diagnostic markers on medical tests, leading to frustration and repeated doctor visits. The differences here are that in somatic symptom disorder, the distress and preoccupation with symptoms outweigh the actual physical severity. In medical conditions, symptoms have a clear physiological basis, though psychological distress can absolutely still play a role. So the example here, 2 people are experiencing chronic pain. One has fibromyalgia diagnosed by a doctor after ruling out other conditions, which may take a really long time. Other has somatic symptom disorder where the pain itself is amplified by excessive focus, anxiety, and avoidance of normal activities. And then moving on to just talking about symptom amplification, stress, and maladaptive coping. The brain and the body don't operate separately. Stress, trauma, and unhelpful coping mechanisms can exacerbate real medical conditions, right? This is all over that book that you love, The Body Keeps the Score. Stress and emotional distress can heighten symptom intensity, making medical conditions feel worse. Maladaptive coping, like avoiding physical activity out of fear, excessive symptom checking, can reinforce symptoms instead of helping recovery. So an example here is a client with IBS may notice that their stomach pain worsens under stress. If they also have somatic symptom disorder, their worry about symptoms becomes a bigger problem than the symptoms themselves, leading to more distress, more doctor's visits, and more avoidance behaviors. So how you can navigate some differential diagnoses, because this one might be the most difficult one that we've talked about yet, because generally there is some sort of underlying medical condition, and also there's just really normal expected anxiety on top of it. So we want to ask about the emotional response to symptoms. Is the client distressed primarily by the symptom itself or what they believe it means? You look for patterns of symptom-related behaviors. Is the client checking, avoiding, or seeking reassurance excessively? And consider the client's response to medical reassurance. Are they relieved by negative test results or more anxious that something was missed? And then we want to collaborate with the medical professionals. These diagnoses don't mean that symptoms are fake. A team approach helps validate the client's experience while also addressing psychological distress. So we're just going to do a really quick case study here. And we're going to talk about Chloe. She's a 17-year-old girl who has spent her entire life believing she's seriously ill. She's made a long list of chronic medical conditions, including asthma, diabetes, heart problems, and paralysis that require constant medical attention. She takes multiple prescription medications daily, uses a wheelchair, and depends on her mother for all aspects of her care. However, as she grows older, Chloe begins to question her illnesses. She notices that her mother controls her medications and medical visits, and that doctors rarely interact with her directly. One day, she discovers a bottle of medications prescribed to her mother, not her, despite her mother insisting that it's essential for Chloe's treatment. As Chloe investigates further, she realizes that many of her symptoms may have been induced or fabricated by her mother. So I want you to pause the lecture here and consider what Chloe's diagnosis might be. Based on her symptoms and history, what DSM-5-TR diagnosis would best explain Chloe's condition? And consider the following. Who's responsible for the illness behaviors? What is the suspected motivation? And is the illness real, exaggerated, or intentionally caused? So pause here, come back when you have an idea. So I'm talking about Chloe Sherman, and she's from the 2020 film Run. And she's not actually the patient in this case. Her mother is. And I know, I tried to trick you. Chloe's symptoms and disabilities were intentionally induced and fabricated by her mother, making this a classic case of Munchausen syndrome by proxy, but now called factitious disorder imposed on another. So this fits because Chloe's mother, Diane, intentionally induces symptoms by administering medication that makes Chloe sick. There's no clear medical cause for Chloe's disabilities. Her illnesses are created and controlled by her caregiver. Diane seeks attention and validation from the medical system by portraying herself as a devoted caregiver. And despite harm to Chloe, Diane has continued her behavior, which is characteristic of factitious disorder imposed on another. So you might be asking, why not another disorder? Why not illness anxiety disorder? This one is about fearing illness. Chloe wasn't preoccupied with her health concerns. She was manipulated into believing that she was sick. And the key distinction here is Chloe didn't create the symptoms. Her mother did. Why not somatic symptom disorder? This one involves genuine distress about real symptoms, which is true, even if no medical cause is found, which is also true. But Chloe didn't develop these symptoms on her own. They were externally induced. And then we also want to ask this question, why not malingering? Again, not a diagnosis, just a fancy word that involves faking illness for external gain, money, legal benefits. Chloe's mother didn't seek financial benefits. Her motivation was psychological gratification from playing the caregiver role to her daughter, Chloe. And when we're looking at comorbid conditions and cultural considerations, also remembering that Chloe's not our patient, it's Diane. So Diane might also have narcissistic or borderline personality traits, like intense need for control, fear of abandonment. She might have a history of past trauma. Many perpetrators of Munchausen by proxy have a history of childhood medical neglect or excessive medical attention. She might also suffer from depression and anxiety, as underlying emotional dysregulation may fuel her behaviors. And in Western medicine, parental control over medical care is assumed to be protective, making Munchausen by proxy cases even more difficult to detect. Some cultures place high value on caregiving roles, which could make factitious disorders harder to identify if medical control is normalized. So the question here is, if Diane came to you for counseling, where would you start? So in the summer, you're likely going to be taking a class on testing and appraisal that's going to look at assessment. So in clinical practice, assessing somatic symptoms and related disorders is not about proving whether symptoms are real. They are. The goal is to determine whether a client's physical complaints are excessively distressing, impairing, or driven by psychological factors rather than solely the result of a medical condition. And many of your future clients will arrive convinced that they have severe medical conditions, and they may already have undergone extensive medical testing before seeking counseling. Others may have been told that their symptoms are all in their head and feel frustrated, invalidated, or even angry at the medical system. And this is where assessment plays a key role. Are symptoms interfering with daily life? Is the client excessively preoccupied with their health? And are health-related behaviors like doctor's visits, checking, or avoidance reinforcing distress? So let's break down how to assess and diagnose SSRDs effectively while preparing you for your upcoming assessment course this summer. So we want to start with clinical interviewing and history taking. Unlike other mental health conditions, diagnosing SSRDs requires careful consideration of how symptoms impact daily life, rather than just determining whether they are medically explained or not. So we want to focus on distress and impairment, and we want to identify excessive health-related behaviors and avoidance patterns, and we want to look for emotional triggers of physical symptoms. So you might ask, when did your symptoms start? What was going on in your life at that time? Do your symptoms get worse when you're feeling anxious or overwhelmed? And then you're also going to use some standardized assessment tools to help quantify symptom severity, health anxiety, and distress levels. And these tools can be really useful for diagnosis, treatment planning, and tracking progress over time. So there's a couple listed on this slide. and that I would recommend you checking into or even looking more into if you're interested in this at some point in your course next semester. You're probably going to have to pick a tool overall just to look at it a little bit more closely. And some of these could be like really great ideas to look at if you're interested in these somatic symptom disorders. What you want to make sure that you do in the assessment part of this process too is really work to establish some interdisciplinary collaboration. So we want to work alongside the medical providers that are treating our clients. And SSRDs often require a team approach. So think counselors, primary care physicians, specialists like neurologists, and sometimes even physical therapists or occupational therapists can all play a role. So we really want to do this to avoid that medical ping pong effect. So clients with these disorders may go from doctor to doctor to doctor seeking a diagnosis that explains their symptoms. Medical providers may feel frustrated or dismissive, reinforcing the client's belief that something is seriously being overlooked. Counseling can break this cycle by addressing the emotional distress surrounding the symptoms. We want to validate their concerns while preventing unnecessary medical procedures. So we don't want to tell a client, oh, it's all in your head. Instead, we'll frame it as your symptoms are real, and we know that stress, anxiety, and emotion can have a huge impact on the body. Let's work on ways to help you feel better physically and emotionally. We also want to avoid excessive medical testing that reinforces that sick role, but encourage reasonable medical follow ups. And we're going to want to work to build a collaborative treatment plan. So, counselors are going to coordinate with doctors to create an integrated care plan. So, an example is if a client with illness anxiety disorder repeatedly requests unnecessary medical tests, their physician may focus on reducing excessive workups while the counselor works on cognitive restructuring and reducing reassurance seeking behaviors. And so at this point, you know the usual treatment approaches: challenge unhelpful thoughts, reduce avoidance behaviors, improve quality of life instead of chasing symptom elimination. And the same is true for somatic symptom and related disorders, where the real goal isn't to prove or disprove symptoms, but to help clients break free from the cycle of fear, distress, and symptom hyperfocus. Cognitive behavioral therapy remains the gold standard, helping clients identify distorted illness beliefs, reducing excessive checking, avoidance behaviors, and reframing their relationship with symptoms. Clients with illness anxiety disorder, for example, learn to tolerate uncertainty instead of seeking endless reassurance, while those with somatic symptom disorder work on reducing symptom related catastrophizing. Mindfulness based stress reduction is another effective approach, teaching clients to observe their bodily sensations without fear or judgment, something that's crucial for breaking that cycle of hyperawareness and anxiety driven symptom amplification. And similarly, acceptance and commitment therapy helps shift the focus away from symptom elimination and toward building a meaningful life, even when discomfort is present. Pharmacological options, when used, are aimed at the underlying mood and anxiety disorders that fuel symptom distress. SSRIs and SNRIs can be helpful in reducing health related anxiety, obsessive symptom focus, and depressive symptoms, but they should never be the only intervention. When it comes to benzodiazepines and opioids, I'd be extremely hesitant to co-sign their use in SSRDs. Doctors may prescribe these medications in an attempt to reduce symptom distress because, yes, the pain and the discomfort is real, but what are we actually treating? If the underlying driver is anxiety, trauma, or emotional dysregulation, masking symptoms with these medications can be a short-term fix with major long-term risks. Benzodiazepines in particular may reinforce symptom monitoring and avoidance behaviors, making it even harder for clients to learn how to tolerate discomfort or uncertainty. Meanwhile, opioids prescribed for pain-related somatic symptoms can quickly lead to dependence, even if pain becomes the focal point of the disorder. And the last thing that we want to do is create a substance use disorder while treating a somatic disorder. It's one thing to offer symptom relief, it's another to reinforce maladaptive coping strategies that prevent actual progress. For me, the risk far outweighs the benefit, and I'd be looking for alternatives that treat the root cause rather than just numbing the experience. But that's just me. There's tons of opinions out there. So when working with clients who experience physical symptoms, it makes sense to treat the body through the body. And this is where somatic therapies and body-based approaches shine. Because if the problem is expressed physically, the solution should involve physical movement, breath work, and embodied practices. We're fighting fire with fire here. Clients who experience chronic tension, pain, dizziness, or fatigue often benefit from yoga, tai chi, and breath work because these techniques regulate the autonomic nervous system, reduce stress-based reactivity, and build interoceptive awareness without fear. If symptoms are linked to trauma or nervous system dysregulation, somatic experiencing provides a gentle way to process distress stored in the body without re-traumatization. And at the end of the day, treatment isn't about convincing somebody that their symptoms are psychological, or we're not trying to talk them out of their experience. It's about giving them tools to move through the symptoms instead of being trapped by them. Therapy works when we validate distress, disrupt the cycle of fear and avoidance, and help clients regain control over their lives, their mind, and their body together. Somatic symptom and related disorders remind us that the mind and body are deeply interconnected and that treatment must reflect that. We've explored how symptoms are real, distress is valid, and the focus should be on function rather than endless medical investigation. Addressing maladaptive health behaviors, reducing symptom fixation, and integrating mind body approaches allows clients to regain control over their lives. Looking ahead, continued research on neurological and psychological factors will help refine treatment strategies. Understanding how stress, trauma, and brain body interactions contribute to SSRDs can improve interventions that target both psychological resilience and physiological regulation. In practice, holistic, patient centered approaches remain key. This means validating distress without reinforcing illness identity, working collaboratively with medical providers, and incorporating behavioral, cognitive, and somatic therapies. As counselors, our role isn't to dismiss symptoms, but to help clients change their relationships with them so that they can live fully, even in discomfort.